Hi class, welcome to the online session. We are with the second part of liver pathology. We have 6 slides to discuss, starting with slide 1 to 7, that would be liver fluke. We have slide 1 to 9, that's hepatic abscess. Slide 1 to 8, this is chronic cholecystitis. Slide 33, fatty metamorphosis. Slide number 1 and 2 are they are related. This is carbon tetrachloride poisoning. Slide number 1 would be 24 hours. Slide number 2 would be 48 hours. Okay, so by the way, some of the slides are already uploaded in the iLearn system, but some are not yet present. So please bear with me. I still will have to use the actual slides for our session. Okay, so kindly enjoy the show. Okay, so our first slide would be liver fluke. So when you are going to look at the slides, most of the slides that we have would not present with the previous slides that we have, which would mean that there's absence of the nodules, which is consistent with liver cirrhosis. In this case, we would see this normal-looking pattern of hepatocytes wherein they are seen in trabecular sheets. They have the presence of sinusoids as the spaces in between them. In this case, what you have to look for would be the presence of this one, because slide 127 is the liver fluke. And what are examples of liver fluke? We have fasciola hepatica, Conorchi sinensis, and Opistorchis piverini. This would be the liver fluke. I think this would be explained better by Dr. Salaver and company. We can see the presence of the ova in this case. So this is a large duct that would contain the liver flukes. Our next slide would be slide 129. This is hepatic abscess. So in this case, again, we look into the appearance of the hepatocytes. They're still in their normal configuration. So they are seen in trabecular pattern, but now the sinusoids are congested by red blood cells. What is hepatic abscess? It means that there's a presence of an inflammation that would lead to a lot of inflammatory cells. So in this case, what we have to look for would be a lot of inflammatory cells. So this would be the portal area. Portal tracts. We have this one would be the bile duct. This is the portal vein, hepatic artery, and then you see a lot of inflammatory cells within the portal tract. And this would refer to mixture of histiocytes, segmenters. This would be the segmenter. We have segmenter, lymphocytes, histiocytes, segmenter. And there's a mixture already. It is surrounded by abscess formation. And the inflammatory cells are not just limited to the portal tract. In this case, you also have them in the parenchyma. So the inflammatory cells here are surrounded by necrotic debris. Okay. So this would be hepatic abscess. For the cause of hepatic abscess, most often it's identified with bacterial infection, but in Asian countries it can be associated with amoeba, Entamoeba histolytica, with amoebic abscess. Sometimes it can also be identified with other parasites like Echinococcus granulosus. but most commonly bacteria. And for clinical manifestations, our patient would manifest with fever, with jaundice, with hepatomegaly, and pain. That's right upper quadrant. So next slide is slide 128. This is chronic cholecystitis. Chronic cholecystitis would refer to inflammation of the gallbladder. This is sequelae or a sequel to several bouts of acute cholecystitis. Obstruction to the gallbladder outflow is not required, and what we would see in the mucosa would be the presence of lymphocytes. So we try to look at the other areas, you would see the presence of lymphocytes. So they can extend up to the muscularis, and you can also see the presence of here. You have confluence or aggregates of lymphocytes. Sometimes these glands would go into the fibromuscular stroma. We call it as Rokitansky-Askov sinuses. Okay. So what is the etiology? For 90% of cases, it would be gallstone. Next slide will be slide number 32, which is fatty metamorphosis. For fatty metamorphosis, this would refer to lipid accumulation within the cytoplasm of the hepatocytes. So this would be these are the hepatocytes with accumulation, and these are of the macrovesicular type. For fatty metamorphosis, this is also what we call as hepatic steatosis. A pathologic steatosis is referred to as involvement of more than 5% of hepatocytes, 2% with lipid accumulation. Okay, so if it's more than 5%, then it's pathologic. This can be associated with a lot of conditions. So this is non-specific when we are talking about fatty metamorphosis. It can be if you're drinking a lot of Coke every day, or if you do not have regular exercise, or you have a metabolic syndrome like diabetes, or you have an alcoholic liver disease, or a non-alcoholic fatty liver disease wherein we can have genetic mutations attributed to hypercholesterolemia. So it is non-specific. It can be seen in several diseases or conditions. So this is common, especially right now. Then we have slide number 1 and 2, which is carbon tetrachloride poisoning. So carbon tetrachloride is a hepatotoxin. This condition would be mainly seen at the area of the central vein, which is called the centrilobular zone, or what zone is this one? Zone 3. Okay. So what do we see here? We would see reversible change because this is still the first 24 hours. So a sign of reversible change would be this one. They are the steatosis. This is of the microvesicular type because look at the lipid accumulation. They are composed of several small lipid droplets. Okay, several small lipid droplets. So this is called microvesicular steatosis. Okay, and the nucleus would still be present at the center. So this is microvesicular steatosis. You can also see presence of inflammatory cells in the area. So this is chronic inflammation. So that's a sign of still a reversible change. Now we go to slide number slide number 2 would already be a combination of the persistence, a combination of reversible and irreversible change with persistence of the with the carbon tetrachloride. So, what are the changes that we would see? Look at the reversible change first. Okay. So, the nuclei of the cells have been pushed to the periphery, so it becomes a macrovesicular steatosis. And then we also would see the presence of inflammation. So the inflammatory cells are are increasing numbers. So you see a lot of inflammatory cells in the centrilobular area. Here's another area with several of them. And then we would see irreversible changes already, like the presence of cellular death, absence of the nucleus. Here you also have apoptosis. Let us try to look for other. Okay, here you have the presence of apoptosis. This one, with decrease in the size of the cell, diminution in the size of the cell, and then you have the shrinking of the nuclei. So that's ignosis. Then this one here, this one is another sign. Okay, there's still retention of the size of the hepatocyte, but there's diminution in its size. So this is necrosis. Okay, so those are the slides that we have for this session. Kindly check on in the book, okay, for the discussion for different slides. Okay, thank you and good day.